Oops. Good morning, everyone. Welcome to this meeting of the Health Scrutiny SubCommittee. The meeting today is open to the public, and so a warm welcome to everyone in attendance and anyone watching online. My name is Councillor Ruth Milsom. I'm the chair of this Health Scrutiny SubCommittee. And before we start this morning, I'm going to ask Joanne to read housekeeping arrangements. Thank you.
Please can I request that mobile telephones and other such equipment are switched to silent mode so as not to disturb the conduct of the meeting. There is no fire test planned for today. If there is an emergency evacuation, please take instruction from the council staff present. The assembly point is Tudor Square. The meeting today is open to the public and will be streamed live and for subsequent broadcast via the council's website. You should be aware that the council is a data controller under the Data Protection Act. Data collected during this webcast will be retained in accordance with the Council's published policy. By entering the meeting room, you are consenting to be filmed and to the possible use of those images and sound recordings for webcasting. Thank you.
Thanks very much, Joanne. Could I ask members to introduce themselves first of all, please, and our officers who are in attendance, starting with Steve.
Yeah, good morning. I'm Councillor Steve Ayris, a councillor for Graves Park Ward in Sheffield, and I'm Deputy Chair of the Health Scrutiny SubCommittee.
Good morning, I'm Anne Wishaker, Councillor for West Ecclesfield Ward.
Good morning, I'm Councillor Sophie Thornton, Councillor for Beechcliff and Greenhill.
Good morning, I'm Councillor Julie Grocutt, Member for Stocksbridge and Upper Don Ward.
Hello, Councillor Rob Bannister for Graves Park Ward.
Morning, I'm McClean, I'm a councillor for Walkley Ward.
Toby Mallinson, councillor for Hillsborough.
Morning, I'm Lucy Davis, I'm the Chief Officer of Health Watch Sheffield.
Joanne Cooper, Democratic Services.
Good morning, everybody. I'm Laurie Brennan. I'm the Head of Policy and Partnerships, and I'm standing in for Deborah Glenn today.
Thank you all. Any apologies for absence this morning?
Just Councillor Rooney.
Thank you. And any items for exclusion of the public and press? I think none. Yeah. Okay. Declarations of interest. If members have an interest in any of the items of business, could you declare it now, please? None? Thank you. Good. So on to item 4, which is minutes of the previous meeting. Have members read through already? Are we happy to take the minutes? Do you want me to go through page by page? Any comments? Yes, Councillor Mallinson.
Yeah, just the supplementary questions that I'm still awaiting. If it could be noted that I'm still awaiting those, and it would be good to be given a time scale of when I will receive those. Thank you.
Thank you, Councillor Mallinson. I will talk to Deborah Glenn next week. I know this is work in progress, but I'll get Deborah to give you an email with an update, and obviously make sure you get the answer to the questions you asked. Thanks.
Any other comments on the minutes? Are we happy to accept those minutes as a true record of the last meeting? Thank you. Okay. Public questions, statements and petitions. We've received no public questions today. And members' questions also, we have received no new members' questions. So our first main item of business is urgent care performance, which will start with a report from Yorkshire Ambulance Service, after which we will pause for comments and questions, if that's all right, and then we'll go on to the planned care part of the agenda, aware that there might be a little bit of crossover, but we'll try and handle that sensibly as we go along. So, for the Yorkshire Ambulance update, if those presenting would like to introduce yourselves and then go on to your presentation, that would be great. Thank you.
Good morning, everybody. My name is Mick Smith. I'm the Chief Operating Officer for the Yorkshire Ambulance Service. Good morning, everybody. My name is Adam Leyland. I'm the Director of Partnerships and Operations for South Yorkshire as part of the Yorkshire Ambulance Service. So what we'll probably do is do it as a little bit of a joint action. For my role being looking at the Yorkshire number wide and give an overview of probably how the ambulance service works, might just help set some of the context. And then Adam will run through things that are local to Sheffield and South Yorkshire. So I'm not sure what members know how the ambulance service operates, but if you just probably a few minutes just to run through the process and how it flows through. So when a member of the public rings 999 and the call is taken by BT, then passed on to the ambulance service, and we answer that call in one of two places, which is our contact centre in Wakefield and another contact centre in York. Those contact centres are staffed primarily by what we call EMDs, emergency medical dispatchers, and they are member staff, not clinical members of staff, but the well-trained members of staff who follow a algorithm by asking questions to the members of the public who's making the call, and from those questions we identify the seriousness of the call. We call it categories, category 1 being immediately life-threatening, level 2 being life-threatening, and then working down to a called level 5, which is usually a patient who can be dealt with without sending an ambulance and given remote support. Once those calls are allocated and identified of category, then our dispatchers in the same centre then identify the nearest ambulance to send based on the category. Category 1 call is immediate. We will find the nearest ambulance, even if that is already en route to another call, and will be diverted. So that is primarily cardiac arrest and severe breathing challenges. The category 2 calls we send again immediately after category 1 priority. And then category 3 calls, they probably wait a little bit longer sometimes, and they are sent after we've covered cat 1 and category 2 calls within there. What we try and do before we send an ambulance is to find an alternative solution for the patient. We want to make sure that the patient gets what they need as close to home as possible. So what we have done over the last probably 5 to 10 years, we've started to increase the number of paramedics, extended trained paramedics who work in our contact centres. So when we identify a call that may be able to be treated by a clinician in the contact centre, that call gets passed to what we call a senior clinical advisor to call the patient, talk to the patient and try and identify if there's an alternative. Those alternatives are based on what's available in that patient's local area. There may be opportunities to give advice for that patient. So that probably, we're doing about 17-18% of all calls now, 999 calls that we get, we're able to identify and treat in that way, which is a significant change over the years to do that. And that is really our ambition, is to build that and make sure patients get the care that they need. When we have to send an ambulance, when the ambulance crew get on scene to that patient, then again, they've got various options on what they can do. They can treat the patient and convey to hospital. And what we try and do is try and find an alternative for those patients. So when we've done a face-to-face assessment, it may be the patient needs access to from a falls team, from a respiratory nurse to come in and provide other support without the patient having to go to hospital. And as a result of that, we've seen a big reduction over years in how many patients we take into, the percentage of patients we take into ED departments. Overall, our demand increases year by year. We also, as an ambulance service, we provide 111 through our urgent treatment centre, so our integrated urgent care centre. So when people ring 111, we answer that call, and again, we go through an algorithm, which is called NHS Pathways, and again, that tries to identify to give patient advice or identify an alternative route for that patient to receive the support that they need. If we identify very quickly on that 111 call that there's an emergency, that is a life-threatening condition, that is sent immediately, electronically, into our 999 centre for an immediate dispatch. We trying to bring those two areas together now and share clinicians, and that is a real priority for us to do that. The third main service area that we provide is patient transport service, and that's for patients who go primarily for routine outpatient appointments and also for life-saving renal dialysis. That renal dialysis works 24/7, 7 days a week, 365 days a year, and is a critical part of the service that we provide. underpinning all that is our what we call a Mersey EPR team, which is a emergency planning team that should ensure that we are able to respond to the unpredictable incidents that may occur. And we have services such as the HEART team, hazardous area response team, and also links to the Yorkshire Air Ambulance. So that is an overview of where we are and how we operate as an ambulance service, to set some context of how we respond within there. So as an ambulance service, we get monitored very closely around our category 2 response times primarily. That's the average time it takes us to respond to a scene. Historically, it's been 18 minutes average response time. That's been the target set by NHS England. For this year, there's been an interim target of 30 minutes. But unfortunately, so far this year, we are exceeding that standard. And that is in line with other ambulance services. It's been very, very challenging to achieve that. Adam will come on to what it means on a local basis within Sheffield, which is a slightly different picture within there. But generally, it is a challenging position to get to. One of the key impacts on our ability to respond to patients is demand and also handover delays at hospital. We have challenges across the whole of Yorkshire. We've got hospitals where our crews can be delayed handing our patients over into the emergency departments. Our average for December, across all Yorkshire was 37 minutes average handover time, the target being 15 minutes. We work very, very closely, as Adam will explain, very, very closely with our colleagues in the acute trust in order to ensure that we get the best flow, that we make sure we're bringing patients who really do need to ED into that area and utilise alternatives wherever possible. Adam, if I pass on maybe to you now around what that means from a local perspective.
Thank you, Nick, and thank you to the committee for inviting us as well. I think from my perspective, the starting point is we, as Yorkshire Ambulance Service, working with Sheffield Teaching Hospitals and the Integrated Care Board, we have some fantastic partnerships across the city to enable us to get the best response possible to patients. And as you can see through the report, our average category 2 ambulance response in Sheffield specifically for the year to date from the 1st of April to the end of December 24, we are getting to patients within on an average of 27 minutes 13 seconds, which is against the current national performance standard of 30 minutes, which Nick explained. And as Nick explained, the more higher category patients, so those that we identify as immediately life-threatening, so the category 1 patients, we are responding to on average within 7 minutes and 10 seconds against the national performance standard of 7 minutes. So to enable us to achieve that, despite the increases in demand and despite everything that we've just spoken about, we're doing that through the partnership work that we've got across the city, and particularly the initiatives that we've introduced, where we have introduced increased hear and treat. So as Nick was explaining around our contact centres, when people and patients call 999, we've supported through clinicians to enable better access to different parts of the city services through the health and care providers, so that those patients can be dealt with more effectively in their homes and where they need that service. We've also been working very hard on increasing our staffing numbers across South Yorkshire as a whole. So we've had an increase this year, over 100 additional members of staff, and we've increased the number of ambulances associated, therefore, to respond to patients. We've had a fantastic partnership with Sheffield Health and Social Care to respond better to patients in mental health crisis. So we've introduced a mental health response vehicle in Sheffield. That has been extremely successful, and we've worked very, very hard to develop different pathways for patients to get them to a better service at their time of need, which is also supporting Sheffield Teaching Hospitals of making sure patients aren't in the emergency department for excessive amount of time. We have introduced something which we call in Yorkshire Ambulance Service called ambulance vehicle preparation. So this is an innovation to support our ambulance clinicians to be able to respond better to patients where they're not having to clean the vehicles and get them stocked at the beginning of their shift, which makes sure that ambulances are available at the earliest point of the clinician starting on duty. That is enabling a 24/7 coverage at one of our ambulance stations in Sheffield at the moment, with plans to introduce it to one of our second ambulance stations in 2025. And more importantly, throughout the winter period where we often see excessive demand just due to the nature of patient conditions, we have been working extremely closely with Sheffield Teaching Hospitals, and we've introduced a senior sister at the emergency department to support ambulance handovers, and we have seen improvements as a result of that in its entirety. Across Sheffield, we have one of the best conveyance rates from an ambulance perspective. So a conveyance rate is dependent on the patients that an ambulance physically goes to, and therefore when we convey them to the emergency department. So we're currently operating about 47% in Sheffield, and compared to other parts of South Yorkshire, that is the best that we've got. It can range up to about 55 to 60% dependent on the day in other parts of South Yorkshire. And that really helps that partnership approach of making sure that the emergency department can operate as effectively as possible, but more importantly that patients are getting to the destination that they absolutely require rather than having to go through the emergency department from the outset. And you can see through the report that we've reduced that over the last financial year from about 51.5%. So we're really focused in Sheffield and across South Yorkshire and more broadly across Yorkshire Ambulance Service of making sure those patients that present to us through 999 or 111 are getting the best response that we can provide presently, but also more importantly getting to the destination or the healthcare provider that they need at that immediate moment in time as well. Of course, there's always more to do on that, and as I said from the outset, we work very closely in partnership to develop those clinical pathways for patients and to make sure that we are collectively, as a system with the ICB and Sheffield Place, doing the very best that we possibly can for patients at the time that they need any of our help in its entirety. I think that's all I was going to say, Councillor Milsom, if that's okay from an opening perspective.
That's great, thank you. So we'll take comments and questions from members, if that's all right at this stage. I see Councillor Grocutt's hand and then Councillor Mallinson.
Thank you for coming today. Thank you to all the ambulance staff who do a phenomenal job, very brave people and often work in very difficult conditions, and we do thank them for that. Stocksbridge, where I live, we seem to have more than our fair share of the air ambulance coming in to deal with incidents, so that is a fantastic facility that I know lots of people in my ward have benefited enormously from, so thank you for that. Obviously, with regard to the ambulance service, all we ever seem to hear are the horror stories of waiting in ambulances and things like that. It was reassuring to hear about the sister system you've got going on in hospitals and reducing that wait. But I suppose it's about, is there anything more that can be done that we can assist you with to make sure that we can really get those wait times, particularly when people feel that, oh, I'm on my way to the hospital now, things will be okay. To be stuck in an ambulance, we all know is not ideal. So it'd be nice to understand that. I was really pleased to read about the mental health response vehicle, and it'd be good to know some more about how that is working, if there's any plans to widen that service, because obviously mental health is a big issue for lots of people in lots of communities, so it'd be good to understand a little bit more about that. And I suppose the real concern for me is the ambulance fleet and estates section of the report that we have, where we're talking about closing down the stations because they're not fit for purpose. So it's about understanding what are the plans to replace it. Obviously, at the moment, they are spread geographically across the city, so I would imagine work quite well. So it's understanding, is this just going to be one centralised point, or are we going to still have the stations across the city so that they've got better and continued access? Because it's taken me to drive 11 miles to get into Sheffield this morning. It's taken me an hour, and I frequently see ambulances stuck in the gridlock traffic. So it's about making sure that we've got a good spread of the stations if we are moving forward and providing new facilities. Thank you. Thank you, Chair.
Right, thank you for that, and thank you for making comments around our staff as well. And I think we do appreciate that, and our staff really appreciate the recognition of such a nice job that they do. If I pick up the estates, and then maybe you want to pick up the local support and mental health. So from the estate's perspective, from an ambulance service point of view, a lot of our estate is from pre-1974. We have inherited, and over that period of time, you can probably imagine the size of the ambulance service has increased quite significantly. As Adam says, in South Yorkshire, over 100 new staff there, been recruited into there, and new vehicles. So our estate isn't as modern as we'd like it to be. In some areas across Yorkshire, we've actually been able opportunity to implement what we call hubs or superstations, different terms are used, but these are, like you explained, where we've been able to consolidate a number of old stations into a new building that allows us to provide our staff with more support, AVP, and also training and so on. So as part of our 5-year strategy, we have a desire to move in that direction. One of the problems that we do have as an ambulance service, and probably from an NHS perspective generally, is sometimes access to capital. The cost of building these sort of ambulance stations is very expensive and has actually gone up in price quite significantly. So for us to achieve our ambition, we need access to the capital to be able to do that. And obviously we're working very hard around that alongside other parts of the NHS to achieve that. So it's very much an ambition. We don't have any firm plans at the moment for South Yorkshire to do that, but we will constantly look at opportunities, and when those opportunities come along, then we will start to explore in more detail. If we do that, then we would ensure we did that full consultation around both with our staff and the public around what it actually means, and as part of the business case would consider the things you're saying around where it would be located and how that impacts on other main activity routes into the city. But it's definitely a direction we want to go in, but no firm commitment at the moment within there. Anything else around the estate? Around there? Does that answer your question around the estate? Adam, can I pass on to you now to answer some of the other questions? Thanks.
Yeah, thank you, Councillor Grocutt, as well, and again echoing Nick's thanks that we will pass on to our staff from yourself as well. I think, you know, it's quite often that we do hear the horror stories, as you mentioned, but I would caveat that with, you know, every single day we are treating patients extremely well, and our staff are doing a fantastic job to enable that. So the horror stories are unfortunately those individual circumstances which do result, and similarly, as you mentioned about waiting in ambulances at the emergency department, there are certain days where our demand for both the ambulance service and the hospital is outstripped compared to the resources that we have available, but that's not every single day. We have seen through the initiatives that we've done some really good improvements to patients waiting, both for an ambulance response, but also to go into the emergency department from what we call a handover perspective. The mental health response vehicle is a fantastic initiative that's really ramped up this year in Sheffield specifically. We introduced an advanced paramedic in mental health earlier last year, who is an expert in mental health and has been able to support the development of the relationships and the pathways for patients. We have recently invested as an ambulance service into specialist paramedic for mental health. So that involves a recruitment exercise which has identified people who've got a specific interest in supporting mental health patients, and we are educating them through Sheffield Hallam University to undertake a level 7 qualification so that they have additional training to respond in an emergency setting to patients who are presenting with a mental health issue. We have one vehicle that operates out of Sheffield. You won't notice it, which is the best thing about it. So it doesn't look like an ambulance. It's very covert. Of course, it has blue lights on. But again, if you're looking at the vehicle, you wouldn't even see the blue lights unless they're flashing. And so it provides a very different response to patients who might be feeling quite threatened or intimidated by calling a public service and having a big yellow ambulance sat outside the house, and the attraction that can often cause to neighbours and what have you. So it's a very, very good service, and I've been very fortunate as a paramedic. I've worked on the mental health response vehicle, and I can see the benefit that it gives to those patients in a very discreet way. when they are in crisis. And as I said earlier, we're very fortunate in Sheffield that the relationship we've got with Sheffield Health and Social Care has enabled us to transport patients to the Longley Centre, which is on the Sheffield Teaching Hospital site, where patients can be dealt with by mental health professionals much earlier on than waiting in the emergency department as previous. But not only is this about conveying mental health patients, this is about getting them the access in their own homes. So we've got some fantastic services offered across the city that we can now access to support mental health patients to stay at their own home and to seek the services and the advice remotely so that they don't have to go anywhere as well. Again, dependent on their needs and dependent on the situation that we've got in the hospitals as well. I think that was all the questions that you asked.
Can I just add a little bit more around the estate as well? It's probably good to explain the way the ambulance is operating now in comparison to previous years. We very rarely now are able to dispatch an ambulance from an ambulance station. What happens now is that the crews will start on the morning at the ambulance station, and then they will be busy all day. They will be into hospital. They will then become available, respond to the next call. The only time to go back to an ambulance station at the beginning, the end of a shift, and if they have the meal break. Yeah, which is a very different model when I was an ambulance quite a few years ago, in that you used to go back to the ambulance station. So although an ambulance station is in the community, it's very rare that there'll be actually an ambulance on that ambulance station, unfortunately.
Thanks for that, Nick. I think it's really worth underlining that. And I was a bit concerned yesterday to see that some of our local media have picked up from the report this ambition to close stations and go down to one. And I think the words NHS and closure, when they're seen in the same sentence, immediately spark a lot of alarm, and that's not necessarily warranted. So I think it's important that you're able to put context around that, especially the way things work today in ambulances basically being out all day and not keeping on returning to a station. So thanks for making that clear. Councillor Mallinson.
Yeah, I've got three questions. One is to follow up on that. I've already had someone contact me about that press article, and they're concerned about longer delays because of ambulances travelling further. And I absolutely accept that if they're stationed around the city, ready to go, that sort of mitigates that. But there's still a concern. You know, obviously it's financially more efficient to have one hub. I mean, obviously the location of that is crucial. It needs to be as accessible as possible from everywhere in the city. So I guess a lot of thought will have to go into where that will be. But it still means that these are staff in these ambulances. They need their breaks. You don't want people making mistakes because they're on call for too long, and it's just an increase in inefficiency if they're having to travel further to get those breaks. Basically, obviously they need toilet breaks as well. I don't know what the arrangements are for that. That's a bit of nerdy detail, but it's important. So that's sort of, if you could sort of pick up those points. And the other two questions are sort of just to pick up on Councillor Grocutt's point. You know, fantastic. I mean, I think the work that you're doing is fantastic overall. You know, it sounds like you're working in an incredibly efficient way, and working to improve efficiency as well all the time. So it's impressive. The mental health support vehicle sounds a brilliant initiative. Does that presumably that coordinates with the police? Because often it's the police who are the first on the scene when there's a crisis going on. Just be interested to know how that works. And final thing is, as mention of a 47% conveyance rate. I just didn't understand that. 47% of what, and you know, what does it mean, conveyance rate, and what does a good one look like, and you know, are we heading in the right direction? Are we in the right direction? Okay, thank you.
Yeah, if I take the first question and pass on to Adam around that. So from a state perspective then, and I do understand the concern around making sure that we locate the hub in the right location. Actually, that's probably secondary. What's really important is that we have facilitate standby points across the city, which is based on really effective scientific modelling. So we look at demand patterns by time of the day and understand where's the best location. If we do have an ambulance available, where's the best location for that ambulance to be based? And what we do make sure is that these facilitated standby points have toilets, they have food microwaves, food for crews get a break, and also even access to do their what we call CPD and ongoing training and education. So there's everything they need in a really highly facilitated standby point. And we've got some good examples like in Doncaster area, haven't we, where they're in place. So it's very scientifically modelled. I just want to emphasise the point as well. We won't just be doing this without working with our wider organisation, staff and consultation around that. So breaks are really, really important. If you pick up with mental health, I'll just mention around what the 47% is, because it gets quite confusing. That 47% is when we receive a call, when we do something with that call, we either hear and treat the call, so we provide support from our contact centre, we either respond and provide support on scene, or we convey somebody to hospital. So 40%, all those three things added together is 100%. So it's that last bit. So effectively less than half of the patients who contact us who we need to do something with end up going to hospital, which I think is really excellent and the way the answers have changed over many, many years to get to that point is really, really good. Adam?
Thanks, Dick. And to say 47% is fantastic across the country as well in that regard. I think just the other bit I just wanted to add from the estate perspective is what I mentioned about the ambulance vehicle preparation and the efficiencies that we get and the support that gives to our staff, our clinical staff, so they can get to patients quicker through that introduction. And thank you again, Councillor Mallinson, for your kind comments towards the staff in the ambulance service as well. That is really appreciated. Your question about the mental health response vehicle and coordinating with the police, we absolutely work very closely with South Yorkshire Police, not only on the mental health response vehicle, but on a number of fronts. And the relationship we have with the police is outstanding, I would say. The introduction last year of the Right Care, Right Person policy enabled us to work really closely with the police, particularly on mental health patients. And that has enabled us collectively to come up with the best response for those patients at that time of crisis. More often than not now we're seeing that the police aren't already with patients unless there's something else going on from a police perspective. And that has benefits and it has disbenefits. You know, it's benefits from the point of view of it de-escalates potentially some patients who are in mental health crisis, but also the disbenefit where people might be a little bit more aggressive than we need the police, and they do respond very quickly and support us and help us as well. So the relationship, as I say, with South Yorkshire Police is outstanding. I think that was all your questions. Yeah. Thank you.
Okay. Councillor Ayris.
Thank you. I'm grateful for having the opportunity for you to come along scrutiny, because I think that we do need to get a little bit more understanding of, because yeah, I don't remember when we've asked Yorkshire Ambulance Service to come along to a scrutiny session before. I endorse the comments and welcome the developments around the mental health response. I think that's a very positive step forward, and you know the progress that you know. So I'm congratulations on that, and I welcome that. Councillor Mallinson also already mentioned working with the other blue light services. So in a way, some of these come from wearing my other hat as a member of the South Yorkshire Fire and Rescue Authority. Okay. And the thing that has cropped up that has puzzled me over time is the the fact that Yorkshire Ambulance Service and the coterminosity of the boundaries with the other blue light services has presented issues in from time to time on a whole range of issues, circumstances. And I'm wondering, and I know that there has been efforts to look at a joint estate review, and that's not really been successful. That hasn't worked. And part of that was because, or part of the reason, as I understand it, was because of the difference in the coterminosity of the boundaries. I think that's my understanding. Correct me if that's not the case. One of the questions I have, and I know that it's a conceptual stage at the moment, because I know that the fire service is undergoing an estates review. The South Police are undergoing an estates review at the moment. What criteria you use or what criteria will you use in order to establish where the ambulance station should be? And I know that the fire service, for example, we have to periodically undertake a community risk management plan process, which we're going through at the moment, based on hotspots, a heat map, to use the jargon, of where the risks are. So it's a risk-based approach. And I'm just wondering how YAS go about that exercise, and how that will drive the decisions on the location of ambulance services. One of the questions for example, I know that from time to time, the fire service are called to go across boundaries with Derbyshire, for example, and vice versa. I'm just wondering whether that has an impact as well, as a sort of a separate question. Thank you.
Thank you. I'll pass on to Adam in a second from a local perspective around South Yorkshire. But from an estates perspective, and you mentioned about borders, we are fortunate in Yorkshire Ambulance that we cover the whole of Yorkshire number, and from there we have a number of different blue light services that we have relationships with. What we did probably about 2 years ago was we introduced a role that Adam does for South Yorkshire, in that we have a senior director who can sit and have those relationships. Adam I'm sure will explain a little bit how great those relationships are around there. So there's very little problems around the borders, and that would not stop us from implement anything that would benefit patient care. The borders with other ambulance services as well, which has historically been a challenge. Again, the way that we operate now is that if a call becomes straight over the border within just into Derbyshire, then we have very quick systems of identifying the nearest ambulances to respond to that patient as well. On the estates, we absolutely are looking at all options across the Yorkshire number of how we can work with all parts of the public sector around our estate. As mentioned before, any opportunities, we're really interested in progressing those, and it's based very much like the fire service around demand and where the risk is and the best location within there. Adam, can I pass on to you to talk around relationships in South Yorkshire?
Thank you, Councillor, as well, and we're grateful for the opportunity to come and talk to the committee. And as Councillor Milsom knows, we came to the Joint Health Overview Scrutiny Committee last year as well, so it is great to be back. Thank you for your congratulations on the mental health response vehicle as well. It is something we're very proud of. And as Nick rightly says, we do have, not only with the police, as I answered with Councillor Mallinson, we have fantastic relationships with South Yorkshire Fire and Rescue Service also. And we are coterminous from a boundary perspective, so South Yorkshire is South Yorkshire for an ambulance service as it is for the police and fire. We do have joint initiatives on estate in other parts of the area, so particularly Doncaster area, we're coterminous with the fire on some of their stations in Rossington and Edlington. And it is absolutely part of what Nick says, the opportunity for us to strategically review together as public services, but also where our patient demand is in its entirety. And because we operate very different services, the demand is not always exactly the same from that perspective. But we will be working to look into that as well. I think they were all your questions, Councillor Ayris. Is that?
Yeah, I think that's the sort. I just wondered whether sorry about that. Whether there's a time scale for looking at, you know, we're going basically on the article that appeared in the press, basically. You know, I'm just wondering whether it's something that we may need to sort of revisit in due course. Is there a time scale?
Yeah, we have our strategy that was developed from last year, 5-year strategy. Within there, we've identified the areas where we would prioritise if we had the opportunity, our hubs. That very much depends on the access to capital and opportunities with, for example, with the other emergency services. So we're constantly looking at that. There are, we have a states group that our states leader work with other organisations in order to, so we're aware what's happening, so we can actually at an early stage express an interest in developing something further. Does that answer your question?
Can I just chip in since we're on that topic, just to ask, just in theory, as obviously it's been thought about to a certain extent and it's in the strategy, with the current estate, so there are 3 ambulance station sites in Sheffield, and talking about developing a brand new site. So would there be a financial benefit to the service of closing those sites? Would there be disposal, or might they be redeveloped to something else within the service or within the NHS purview?
It's hard to answer that question. That would be part of a development of a business case around that. It would depend on what we wanted to. We might just not dispose of some of the estate if there was another purpose for that estate. So it would very much depend on the individual opportunities that arise, whether or not we would actually close ambulance stations down or not. So I guess I don't really answer that one at this point.
Thanks. I mean, it's early stages, isn't it? So, and I think,
aspiration.
Yeah. Okay. And the important thing, I think, for us to understand as a committee is that if you reach the stage of that actually going forward towards consultation, that you'd involve the committee at an early stage on that, and we'll know about it in a timely way. Is that on this one, Luce, on this topic? I've got Councillor McClean, Councillor Thornton, Councillor Whittaker, and then Lucy.
Thank you for coming today. I had just a quick question about the conveyances. It's just really good to hear that that's working really well in Sheffield in terms of the rate being low. And it's also really good to hear that you've got good partnership working. But I just wondered if there's any more work to be done in that space. Have you got any plans that, if that's something that's continually being looked at, have you got any plans that could further sort of work, build on the good work that's already going on? Thank you.
Thank you very much, Councillor McClean. Absolutely, there is always more to be done. But the last 2 years since I've been in post, we've really strongly developed those relationships, which enables us now to properly challenge each other on the evidence that exists and the data that tells us where we can do things differently for patients. So we have set in our strategy about being a great partner, about developing new relationships and making sure that we maximise upon the opportunities that exist for our patients collaboratively across the system. And we work very closely with the ICB to make sure that all of the aspects of the system are able to deliver the care that the patients need, regardless of who they present to first, if that's the ambulance service or elsewhere. So there's always more work to be done on that, and as new services develop, we make sure we access them as quickly as possible from an ambulance perspective as well. Thank you.
That's great. Thank you.
Thank you, and thank you for bringing this report today and for taking the time to speak to us. We really appreciate it. We've spent quite a bit of time talking about the estates, so I want to focus on handover times, if that's okay. I wanted to see, just in terms of benchmarking and comparison against other hospitals, say regionally like Leeds, how does handover times at the Northern General Hospital compare to others in our local areas?
So from a Yorkshire number perspective, we have a number of sites that are challenged. That is very much within the North Yorkshire area, York, Scarborough and Hull in particular. And then within West Yorkshire, generally better, quicker handovers within the Leeds area. And in South Yorkshire, Doncaster and Sheffield, the Northern General are usually areas where we have challenges as well. But there's so many other underlying reasons, so many variables on that and why that's the situation. And I'm sure a colleague can maybe explain a little bit further on than that one. When we compare ourselves as an ambulance service to other parts of the country as well, it's a problem everywhere. It's a challenge of pressure in the system to do that. And we're probably benchmark probably in the middle around the amount of delays that we have in comparison to other areas as well. Adam, do you want to talk on a local basis?
Thank you, Councillor Thornton. And you know, the opportunities that we have from a handover perspective are about that innovation and the testing of different things. So as we've done over winter with Sheffield Teaching Hospitals, introducing the streaming nurse as an innovation to test actually, is that going to make a difference? Is that going to help? And the evidence so far is that it has. And we're trialling different things across different parts of South Yorkshire and across the Yorkshire and Humber area as well. So we can learn from those aspects and then adapt them as necessary. But we need to give them a good chance of trialling something first before we do that. And likewise, you know, part of the ambulance service, we are part of the entire country's ambulance service network. So we often share things from across the country to see where people have made a difference and made an impact on particularly handovers in this case. And that's what leads to some of our innovations and some of our adaptations to those innovations from elsewhere in the country. So it fits the needs of our people in Sheffield, for example, but also meets the differences that exist across the NHS from a local perspective.
Thank you. Obviously, with handover times being a challenge, particularly at Northern General, I mean, anecdotally, I work on a learning disability service, and a few months ago we had an issue where a lady had over 8 seizures, a rescue meds hadn't kicked in, and we phoned 999 as we should do at that sort of time, and an ambulance couldn't come. And eventually we took a risk and took her into the Northern General, and there were queues of ambulances waiting outside. One of my good friends is a paramedic and was saying just last night there were over 20 at one point waiting outside the Northern General Hospital. Some of them had been waiting over 5 hours. So obviously that's quite concerning. And certainly when we've had it, when I've seen it from the other side and seen how long that has impacted on people's care. And the waiting times that they've had, to the point where we ended up taking her in ourselves. How can you be assured that you can provide a safe level of care when you've got queues of 20 plus ambulances waiting outside Northern General Hospital?
If that's okay, Chair, I'm happy to come in from a STH perspective. So as Adam and Nick have mentioned so far, some great collaborative work across the system at play, supported by the ICB, because absolutely clear handover times have an impact around the patient that's waiting to be handed over, the patient in the community, but often then the impact being driven by the occupancy at STH. And coming back to Councillor Grocutt's question earlier on in terms of where can the committee support, I'll go through the data later on, but the data absolutely shows that the number of no criteria to reside patients that we have at STH is linked to our occupancy, which is linked to our A&E department and then ambulance handover. So absolutely clear there's work to be done across the whole system. At the front door, when we're in the position where we have challenges for handover, we've got some very clear protocols within the A&E department, which are around working with the ambulance service to identify who has arrived and what is their clinical priority. So assessing that, working closely with the team so that we are clear if there is anybody that needs to be in the department, how we support that, and particularly if it's for increased clinical care. So we have that system there. The streaming service, sister, as Adam describes, has shown significant improvement in those handover times, and that's about identifying patients that may have arrived by ambulance but can check in themselves, so we can get them in the department and supported that way. Again, highlighting, and we do rounds by the clinical teams with the ambulance service, looking at who are the patients who need further input or further support. So whilst we do have times, unfortunately, where we've got patients waiting, we're absolutely working between the clinical teams in A&E to prioritise and bring the patients in. Adam and I have then been on a conversation earlier this morning around further improvement work, which is very much around the STH occupancy and flow piece, which is about how do we improve further the time that patients are waiting, and look to, as we come out of winter, we talked when I came before Christmas about our winter plan, which was very much focused around the risks that we see for ambulance handover, but the work that we've been doing within STH about matching our capacity so that we can provide flow out of the A&E department and get patients into beds when they need, and we've agreed a kind of a system-wide programme over the next couple of months that will drive that further and hopefully get further improvements on it. So definitely in the there and moment on the shift management through the clinical teams, but then through our wider teams, absolutely looking at further improvements that we need to make. So I hope that's helpful given the STH perspective.
Could I just come back to your point around safety as well? I mentioned earlier that we have our contact centres where we look at the jobs that are outstanding, and we have clinicians at time of escalation that constantly review that stack of calls, those patients, to understand where there's a risk within that of calling the patients back. And we have something called duty to rescue, which is agreed across the whole of Yorkshire number, where if our clinician in our contact centre identifies a patient of immediate risk of death, then they will be to implement duty rescue, and immediately a call is made to the department, ED department and the crew, and we release a crew to respond to that patient. It isn't used very often, but we always have that in place. Adam, I'm not sure if it has actually been used in South Yorkshire, but it has been there.
And yeah, just to follow on, first I'm really sorry to hear that experience that you had. It's not what we expect overall, but I can assure you we are doing everything we possibly can to make sure those experiences diminish as much as possible. You know, and as Michael and Nick have said, what we've got in South Yorkshire we introduced last year is something called our Joint Escalation Action Plan, which is a collaborative piece of work between the ambulance service and all of the acute hospitals in South Yorkshire when we are experiencing significant demand or issues with handover and challenges within the hospital, that we've got a very clear, robust action plan that we take to make sure that everybody is concentrating on that safety and making sure that the risk is averted as much as possible. And in addition to what Nick just mentioned about our process called Duty to Rescue, when we do start having handover delays, we deploy some of our managers and our senior clinicians to the hospital to support patients that are waiting as well, and we do that collaboratively with the clinicians in the emergency department. So we try everything we possibly can to make sure that patients and people remain as safe as possible when they're waiting, but also that we have processes to make sure we can get to patients as quickly as possible when they're waiting in the community as well. Thank you.
Thank you. One last question from me, if that's okay, Chair. Was you mentioned about how Leeds and West Yorkshire do significantly better. So what else can we do to reduce the handover times? I suppose is in the long run, is one accident and emergency department sufficient for Sheffield? Does the Hallamshire need relooking at? If we're looking at capacity being seemingly from your responses a big issue, is that something that needs to be looked at across the piece? What else can we be doing?
From a Yorkshire number perspective, we've been doing some work with Umber, with the Hull Royal Infirmary around how we can implement, it's called transfer of care. So we'll look at a target of 45 minutes as a maximum, working that down to 15-minute handover times. That's been successful, and we believe that's a model that we're now working with other hospitals across Yorkshire to see how that could be implemented. It's very difficult, it's very complex, as you can imagine, to do that, but we have seen some positive feedback and positive signs from Hull.
Happy to pick up on some of that. So I think what can we do and what are we doing? So I think it pulls together some of the strands that we've described and colleagues have described today. So continue to work on, have we got the right services out in the community so that our patients can choose well and we can direct them to the right service, so everything that links to the kind of the metric around the conveyance rate, so supporting patients in their own home or to access other services. The work that we've then been doing in A&E around absolutely the streaming sister and the teams and how we have established and the flow that we've got within the A&E department to receive the number of ambulances and the modelling on the work that we've been doing, the number of ambulances that arrive every hour to make sure that we can receive those. We've got some further work to do around flow within the organisation, and so that's around supporting our wards to discharge patients as early as possible in the day, to maximise the number of patients that are going to the discharge lounge and encouraging families to collect their patients from the discharge lounge. It's a much better experience in terms of parking and access to take patients home. It's much easier for the ambulance service to come to a single point on the Northern General, but it frees up a bed for the next patient. So work that we need to do and continue to do around flow within the organisation. And then, as I say, absolutely around ensuring that those patients that are in our beds across our Northern General and Hallamshire sites are patients that need to be in bed. So work on no criteria to reside, ensuring that patients become as fit as possible and supporting them for care back in the home as soon as possible. They're the kind of key strands of the pathway that we continue to work on. I think single A&E department at the Northern General is the right model. The bit we've got to manage is as a system how we use all the different both pre-hospital, within hospital and post-hospital services to maintain that flow around the A&E department and particularly that axis of ambulance handover.
Thank you.
Thank you very much for coming and reiterating what everyone's said. Thank you for the service that you offer us. You've clearly got lots of dedicated staff to do this service. The improvement initiatives that you're putting into place at the moment seem to be excellent, and I'm sure there's a lot more to come in the future, which is brilliant. We talked about ambulance stations merging into one, and that wasn't an issue because ambulances only go there at the beginning and the end of the day. And we're talking about standby points. How realistic is it that staff would be able to use those in terms of, you know, that they're just given a job after job after job, especially in times when, you know, the service is really, really stretched. So it's really good having that type of facility, but how realistic is it that staff would be given that?
It depends on times of the year, it depends on the seasonality. So we know that during December, for many years, we always know it's a pressure point within there. For example, the last 2 weeks, we've seen a reduction in pressure generally across Yorkshire, and therefore we have that ability to utilise our standby points at those times. It is challenging, so we have to make sure that we don't have too many points, that we have enough that to utilise when we are in quieter times. And what it allows us to do in the morning is to strategically locate our ambulances for that first call to be able to respond there as well. So in answer to your question, not as often as we'd like to be able to do that, but we're constantly trying to increase our availability of ambulances, which gives that opportunity then to strategically locate and give our staff some respite, hopefully as well, prior to the next call coming through. Adam, anything to add to that?
Can I just ask a further point? I think we're all aware that the role of a paramedic is extremely stressful. And so are there lots of initiatives in place to actually look after the staff's mental well-being, if you like?
Thank you, Councillor Whittaker, and we'll pass on your thanks as well to all of our staff. There is absolutely a significant amount of support that we put into all of our staff through corporate arrangements. So we have an employee assistance programme, we have specialist mental health access resources available through all of the points that we've got. And more locally, we introduced last year a bit of a QR scanning system where people can self-identify if they're struggling and they don't want to talk to somebody initially, and that alerts one of our managers, so they're able to then follow up with the individuals. And that's just not work related. We support people from all of their personal lives as well, and the access of the resources is fantastic that we can give to people, and we're always looking for different ways to do something different and advance it, and we work very closely with the ICB, who've got different resources available for all NHS staff across South Yorkshire as well.
Thank you, because obviously it's really, really important to look after our staff, isn't it? Yeah.
Very, very important, and it's a priority for us in part of our strategy as well as an ambulance service.
Thank you. We've talked about the really positive introduction of the mental health response vehicle, and it's really good to hear that you've got strong partnerships with SHSC that have enabled that. That's really positive to hear. I was just wondering about the sort of other recent development in terms of mental health crisis response, which has been the introduction of the 111 option 2. I don't quite know the technicalities of how that works, sort of back of house, so I was just wondering if you could describe from your perspective how well that pathway is working. I think there's some potential for public confusion a little bit, because 111 is, for most people, not an emergency service or a crisis response. It's a sort of step down from that, but when you're talking about mental health, actually the messaging is that that is one route to crisis care via the option 2 bit of the menu. So if you could just describe a little bit about how well that works and what the sort of pathway looks like in terms of if it does need a response, for example, from the emergency vehicle, how that works. Thank you.
Thank you. Yeah, I'm no expert on actually flow of call taking, but what happens is when you ring 111, there's that option very easily up front around very quickly, be able to identify if you're in crisis from 111 support. And we worked very closely with other providers across Yorkshire number around. So what we need to do was that if patients selected that, they were able to have a response. It went through there, and we did a lot of modelling to understand from each system that there was enough capacity in order to answer those calls, and to make sure that we had a very effective way of, if there wasn't, how that comes back into the system and prevents patients being bounced around the system as well. So as you can imagine, we've watched that very, very carefully around that, and I think generally it's been very successfully introduced. We've not identified any major problems around that process taking place. And I mentioned earlier, if at any point there's a need from a life-threatening or a serious perspective, we work our systems are linked straight away. We'll be able to pass that on to our 999 service to get an immediate response around there as well. So it works very seamlessly. Obviously, like demand is, if the availability of the service is not there, we can still give the patient the support that they need through alternative means. Is there anything on a local basis, Adam, to that? Or?
So as I said, we work really closely with the mental health providers, and that option 2, when somebody calls 111, puts you through to the local mental health response in the area that you're calling from. So it is still bedding in overall, and if it's helpful, we could provide a written response a bit more full on what that is offering at the moment.
Yeah, that'd be good. I'd welcome that. Thank you.
Just want to add about where we're doing better than other places in Sheffield in terms of response times. Just wanted to add a note that I think we recognise the work that's been done there and the fact that we're getting ahead, and hopefully other places are able to achieve the same. But thanks again to the staff and the way that you've worked out a strategy to make those response times more effective. I wanted to just ask, referring back to Adam, when you came to the joint health scrutiny, and the report you brought to that committee talked about Yorkshire Ambulance Service subcontracting some of the NEPT services, the non-emergency patient transport services, to private providers. And I wondered if you can comment at all about whether that's representing best value for money. Is it a stopgap? Is it a permanent arrangement that is effective? Or could that part of the service be done cheaper in-house, and has that been looked at? You know, if in-house would represent a saving, is that in the scope of the Yorkshire and Humber plans?
Thank you. From a patient transport perspective, we're currently working very closely with the commissions of the service, which is the three ICBs for South Yorkshire, West Yorkshire and North Yorkshire together, around looking how we could actually have a more consolidated approach to the provision of patient transport service. As you can imagine, that we have to work through various processes around that, but that is the aspiration of the Yorkshire Ambulance Service, that we will be able to be that single provider of patient transport services, or NEPs, across the whole of Yorkshire. Our model of providing patient transport service is a mix of our own staff and also our private provision as well. We find that model is a balance between flexibility and obviously from a sustainability, from a financial point of view, to do that. But what it allows us to do is to flex our service to meet the peaks in demand and spikes in demand, such as Christmas Eve, when we know we have a big spike in discharges. We are able then to utilise other resources to meet that. So I think the model going forward will always be a mix of our own employed resource and a more flexible private sector resource within there. But our desire is to have that consolidated approach across the whole of Yorkshire.
Just out of curiosity, this is a little bit off the report, but children's non-surgical cancer treatments, are they still located at Leeds, or have they come back to Sheffield?
I'm sorry, I can't answer that. We could find that out.
Do you know that, Michael?
Radiotherapy, yes, still at Leeds at the current time.
Just radiotherapy. So it was just a thought really about emergency situations for children undergoing cancer treatments. You know, if emergencies arrive, whether they're treated in, whether they go to a Sheffield setting, or whether they have to be transported to Leeds.
That's a planned care. I don't know. I'm sorry.
It's only planned care that's at Leeds.
That's
so
my understanding.
Emergencies would be in Sheffield.
I'd have to just check that.
Councillor Milsom, sorry, I can just add, so we operate the Embrace service in conjunction with Sheffield Children's Hospitals. So that provides emergency transportation to paediatrics and neonates across the area. So there is a mechanism, should transport be required, that we have the appropriate resources with Sheffield Children's Hospitals to do that. But again, I can't answer exactly where treatment is held, but I just thought it's helpful for the committee to know that we do have the transport available if necessary.
Yeah, thanks. Yeah, it was just about emergency treatments, really. Sophie, really quickly, I want to wrap up this item in the next couple of minutes.
Yeah, thank you. Apologies for coming in again, but I just wanted to come back on a point that I think you made, Councillor Milsom, earlier about the cost and the finances of potentially merging ambulance stations in the long run, and whether that would be a financial benefit. Has that been, obviously, I think that's a similar model to what Doncaster has at the minute. Has that been done elsewhere in the Yorkshire and Humber region, and how is the cost of that going?
We are currently, the nearest we do that is within Hull at the moment, is that we're looking at consolidation of a number of ambulance stations in order to support the development of a hub within that area. And it's zero cost balance. What we're trying to do is ensure that we can provide an improved estate without incurring more cost. But not driven from a financial perspective around that initially. It's around providing the best support we can do for our staff and response to the area to do that.
Okay, thank you. With like hubs, for example, I think it was in Scarborough that has come together, and it seems to be like quite massively overspent. Obviously, the investment that you've got then to actually do the great work that you want to do is significantly impeded from that. So obviously, we don't want that to happen here with any potential plans that are being touted to put stations together. But how can we prevent that, and what learning can we take from that?
I think Scarborough is a good example where we bought land for that area. we had a business case, identified the cost of building that, and we identified that it was unaffordable at that point because of the increase in costs. That would have had an impact on other parts of the organisation, so therefore we didn't progress that any further at that time. So we will constantly look at the cost of what it would be to implement something, and our priority is to protect the service provided to patients. To do that, there are savings by developing hubs. We know that around consolidation of some services around there, an AVP and things like that. What we won't do is the jeopardy of actually providing of impact on our frontline services to do that.
Okay. Well, the recommendation to the committee is that the update is noted for comment and consideration, which we've done, so thank you for that. I think I'd like to add that in view of the very, very early nature of the discussion around the estate reconfiguration, that any plans to proceed with that idea of developing a single ambulance station for Sheffield should come to scrutiny at the very earliest opportunity. You can tell we're going to have a lot of questions about it. So the earlier the better that we're able to engage in that discussion, I think. It's very frustrating for us when, you know, it's a statutory kind of obligation of the committee that we do look at transformations like that. And if we're brought in at a later stage, say when a consultation is already underway, it becomes very difficult then to have the right conversations. So the earlier the better, as soon as anything becomes vaguely concrete, I think would be really appreciated. So I'd like to propose that we add that as a recommendation. Mike.
Well, not necessarily written down, but Lucy's request for more information on the 111 pathway.
We can absolutely do that. I just want to emphasise to the group that that there's nothing tangible that we are prepared that we can share at this moment in time around that. It probably is an aspiration to move to that, and there's no plans at the moment to do anything further on that. I just want to make sure that's absolutely clear.
Yeah. Also, you know, just to be really clear that we've understood the context that's been missing, I think, from the BBC report that came out yesterday, which is that ambulances don't behave in the same way as, say, a fire crew that are waiting for a call at a station, that our crews are out basically all day, every day, and it's not reliant on having stations open all around the city. So we've understood that today as perhaps some knowledge that we didn't have before, and I think it's really important that bit of information is publicised. So hopefully we can be helpful in that respect. So with a request for more information about 111 services from maybe Lucy might want to put a bit more context around that in a maybe a written question to Yaz. We could maybe follow up with a written question if that would be acceptable to you. Yeah, great. And our understanding that we'll hear from you at an early stage about any plans for the reconfiguration. Great. In which case, thank you very much for your time. Stay if you're interested in the rest of it. Then I guess it might cross over, or if you need to get away, then thank you. So we'll go on to item 8 is planned care, and we've got an update from Michael.
Could I just grab a glass of water before I start?
I was going to say, if you need a very quick comfort break, please do. Okay, welcome back. And our next item is an item on planned care, which Michael Harper is going to deliver for us initially. And we also have Sarah Burt with us from the ICB, who's online. I'm not sure how we... Just butt in, I think, Sarah, if you want to speak, because we might not notice your hand going up. So please just chip in as and when. Okay, over to you.
Great. Thank you, Chair. So, yes, I'm Michael Harper, Chief Operating Officer at Sheffield Teaching Hospitals. Been asked to provide a kind of an overview of both our urgent and planned care performance. So I'm presuming the slides will be shared as I go along. Yeah, great, thank you. Now, the first set of slides relate to our urgent care performance. Appreciate in terms of how we've had the earlier conversation. I don't want to repeat that, but if I just very quickly skip through each of the data so you can see what data we've provided. This is all pulled from our integrated performance report. Hopefully it just sets context and underlines the conversation we had earlier, but very happy to take any particular questions. So next slide, please. So this is how we present our data in our integrated performance report. As I say, it's a statistical process control chart, so kind of a run of our data over time. So these two show the percentage of patients. So the left-hand graph is the percentage of patients who are handed over in over 30 minutes. So we track that. So the red line is the target at 5%. The black line is the mean, the average of our performance, the black horizontal line, and then the chart shows our performance. So relatively stable around a mean, so no kind of statistical variance on there. But unfortunately, we are seeing more patients handed over in over 30 minutes than we planned to do, and hence the conversation we've had about improvement. And then likewise, the second graph is the number of patients handed over in over an hour, 60 minutes. So absolutely the focus that we plan to have there. The dotted lines that you can just see, that's the two limits. So from a statistical perspective, you would expect the data to fall. The system is established to fall between those two lines. So absolutely, in terms of a focus from an STH perspective on the time that patients hand over. We also track as well the number of patients handed over within 15 minutes. They're the three metrics that are in our IPR. I'll keep going if that's okay, or do you want me to stop and take questions on each? Okay.
We'll take
Apologies,
questions
Chair.
on the graphs as we go along, just to make sure we've all understood what you're saying.
Thank you, Chair. Just to confirm, so over 30 minutes, does that include the over 60 minutes within the over 30 minutes? So so that 60 minutes is a subset of the 30 minutes. Okay, thank you. And the red line, that was, you said 5%?
That's the target.
That's the target, all right, thank you.
Okay, thank you. So the next graph then, and I think the kind of the story that we're attempting to tell in the data is my response earlier to Councillor Grocutt in terms of absolute focus within the A&E department has an impact on handovers, but what happens across the whole place and system, both in and out of the organisation, has an impact. So next slide, please. So similar again, so the red line is the target. So this is the number of patients that are seen within 4 hours. So the red line kind of changes here because the target used to be 95%, was reduced down to 76% and then up at 78% now. Again, the black line is the average of our performance over this time. Each dot represents a month. The coloured circles, so the blue shows that we had a run of data that was above the mean, so positive. The orange, unfortunately, shows that we had a run of data below the mean, and then the black dots more recently kind of show that it's a variance. I think the key bits to point out here, so unfortunately our performance has dropped, this is up to November, dropped running into Christmas, which represents a similar performance to the year before, and this data very much tracks the national performance on A&E performance. So nationally we are very similar, slightly above the national performance, or have been above the national performance. Within STH we track our own performance and we benchmark that against all trusts nationally. and we were the 49th out of 119 performing trusts nationally, but we also track against a large northern acute trust. We think that that's our peer benchmark, and we track against that and perform well against that. So we've got some way to go in terms of improving the performance, and the work that we're doing is around reducing the time that patients wait in the department, but that mirrors the national position, particularly post-COVID, where we've unfortunately seen a reduction in the we've seen an increase in the number of patients waiting over 4 hours in A&E departments. I'll stop there, Chair, and happy to take any questions. Appreciate I'm in and out of this data every day and it's brand new to you, so apologies. Please do ask any questions.
Okay, thanks.
I'm just looking at the comparison of April to the sort of the April onwards section of the year, yes. Compared with 23. We seem to have not performed as well as last year. So what are there specific reasons for that?
So a number of different reasons. So we've seen the number of patients coming to A&E has increased. So part of our response has been about how we respond to that demand, and some of that is linked to the earlier conversations about how we help patients choose well and redirect them to the most appropriate service for them. We've also seen over this time, as we'll come on through the data, overall increase in demand for all emergency services, but then also an increased occupancy around the Northern General in particular, which has an impact on the time that patients wait for a bed in the A&E department, and unfortunately then the impact on performance. So they're the two key factors.
Just to quickly explore a little bit about that. So this is in no way a criticism or doubting anything that anyone said. It's just for me to try and understand. So Adam, from your point of view, from the ambulance point of view, you've been implementing things that are making positive strides in keeping more patients away from A&E when they don't need to be there, and therefore hospital admissions. And Michael, from your point of view, it seems to be getting worse. So just is this pure demand? Is this just a rise in demand? Is it more complex medical needs that are resulting in higher demand on hospital admissions? I believe that Yorkshire Ambulance have made these strides. I believe you're working in partnership, but I also believe that it's getting worse for you because the graphs show us that.
So it is a combination of all those factors, and the work that we've done, and we described it to the committee when we came at the end of last year, in terms of it's really important that we support our patients in Sheffield to choose the right services, and the work that we've done across Sheffield, particularly in terms of the development of the minor injuries unit and the walk-in centre, and then particularly some of the services that working with YAS, where we redirect patients to particularly our community services or other services provided by or commissioned by the ICB. What that does mean is that the patients who find their way to the Northern General are the right patients, but are more complex, do require more input. The configuration that we've got within Sheffield is relatively unique in terms of we have separate children's and adult hospitals. Children on the whole tend to have a lower admission rate and are managed, treated and discharged quicker than adults, who when you isolate them have a higher admission rate. So it's a combination of factors in terms of we are getting the right patients to A&E, but by their nature then there's a higher proportion require admission or diagnosis, assessment and treatment, which has an impact on the length of time that they wait here. So that's a bit that's, I suppose it's a combination of that data that leads to the position that we've got now.
It's really interesting that, and I think from the point of view of for us as elected members and the committees that we sit on, and the work that we tried to achieve through those policy committees in adults and children's services. There's some sort of correlation and something for us to understand about, I guess, the council's part, social care, the effectiveness of community care, the effectiveness of the voluntary sector and how that's supported, all those factors that help people to lead healthier lives and then have less impact for you at the sharp end of things. And I just wonder, are you kind of satisfied at the moment with the way that partnerships work in that kind of area? Is there more we can do? Is there more you can do? Is there more we can do together? And obviously that's a whole other meeting probably, but are there kind of some headlines that you could draw on that would make a really big difference, and things where for us as members maybe areas where our focus could be?
Thank you. So the Emergency Care Board is a place in the city that brings together the different providers. It's chaired by Ian Atkinson at the ICB. I think mirrors what Adam described earlier in terms of I've been in a coup role almost 10 years now, a definite improvement in the relationships across place over the last kind of 2 or 3 years. I think a definite commitment to working together. Some really great innovative schemes in the community that do support patients and provide alternatives to attendance and admission at A&E. I think we're very fortunate in Sheffield in terms of Sheffield Teaching Hospitals is a combined acute and community trust. That's not replicated everywhere across the country. That gives us some fantastic opportunities to work across acute providers and community. We often focus on the A&E performance. We see twice as many patients, our district nurses see twice as many patients in their own home every day than we do in the Northern General, but we often focus on the Northern General, so A&E department, so absolutely kind of that acute community, voluntary sector response is key and pulled together through Urgent Emergency Care Board. I think, again, similar to other cities of our size, the challenges around no criteria to reside and being here at the council, again, the work that we do with Alexis Chapel around that, some fantastic work that we've seen over this past 18 months around the provision of independent sector home care has absolutely helped, but we've got further work to do to support those patients who are in our beds and how we manage and we'll come on and describe in the next slide. We are seeing that increase in the number of emergency admissions, which has seen an increase in the number of discharges, which has seen an increase in the demand on those pathways to support patients in their own homes. So how we respond to that across our community, social care and voluntary sector, that's probably the ask, and the support of this committee to support us with that would be fantastic. Thank you. But it's building on the positive work that we're doing.
Yes, Sophie.
Thank you, Chair. Obviously we talk about keeping people safe at home with the, and that the work that is ongoing, and certainly from myself, Councillor Ayris and Councillor McClean also sit on policy, and Councillor Grocutt sit on policy committee, and the work that we've done on discharge over the last 18 months, as you say, hopefully is making a bit of an impact. But in terms of people that have urgent emergency care, say for example they might have had a major heart attack and need resuscitation, if they're going into an emergency department, how many beds are there, for example, in resus?
So in terms of our resus, ask me a question now. Yeah, exactly. I think we have 8 bays in resus, but can I just check that kind of thing? But what we also have in the city is a number of urgent care pathways. So, for example, we have a pathway for patients who have had community-based heart attacks that would bring them straight into our cardiology unit. If they require catheterisation, they would go on that pathway and not always hit the A&E department. Again, that's working with the ambulance service on that. Likewise, we have the stroke pathway that through the ambulance service, if we identify patients who've had a stroke, they would get taken straight to the Hallamshire and through the stroke pathway. So not every patient on an emergency pathway comes through the Northern General A&E department. We manage, again, through collaboration to get those patients into the right place.
Thank you. I think obviously working on discharge and improving the patient flow is something that's been ongoing and it's not new. Access to 111 to redirect people isn't new. Getting to minor injuries, again, is really fantastic. I've used it many a time. Certainly when I did the Sheffield 10K without training. But, you know, the walk-in centre, again, isn't new yet. Patient demand is still massively increasing. Is there any plans at all to expand any capacity at Northern General? Because obviously that is a bottleneck where there is quite a lot of pressure. So are there any plans at all to expand any capacity? You said in the last report that you think that a single A&E for Sheffield is the right model. So obviously there's no plans there to expand it to Hampshire, but within the site that we've currently got, what's the plan going forward?
So yes, I think building on the conversations we had last time, the urgent care review for Sheffield and kind of Ian Atkinson as Deputy Place Director talked through, I think absolutely understanding what are those pathways, how do we create the right capacity for individual services is really important. We don't at this stage have any plans for expanding the A&E department at the Northern General. It's one of the areas that we have done significant amount of work in. We've developed new areas, so we have a same-day emergency care service. So we reconfigured the kind of the D floor area of the Northern General recently and expanded in effect the A&E department, but by creating a same-day emergency care service. We've developed the clinical decisions unit within A&E. So different pockets within the department have been developed and expanded. Similar to what we heard from Yaz colleagues, we've been working through our capital budget within STH and looking at where do we focus that and how do we develop it. We've got a number of other schemes in development, not the A&E department at the moment. Again, it comes back to if we can manage flow through the department, the number of patients arriving at A&E is absolutely manageable. The work we continue to do is about making sure that the time that patients wait in the department is at a minimum, flowing through to the organisation. That makes the A&E department the right size for the service.
Councillor McClean, sorry, were there any other hands? Yeah, Councillor McClean.
Thank you for this report. And obviously we know that demand at the moment is really high, and that's what you're dealing with today. But what are your thoughts at the moment, sort of looking forward over the next 12 months? Sort of bearing in mind what you're facing at the moment. Sort of, I know it's hard to predict, but how do you feel the next 12 months is going to go, and what are you looking at for the next 12 months to sort of help the system really? Thank you.
Great question, thank you. So again, kind of starting at the back door and working forward. So and Sarah may want to come in online on this. So we're already looking at the Better Care Fund, which is the money that comes in around hospital and social health and social care services around that home care provision, the discharge provision, and going through a process now looking at how do we set up that element of the service. So we've got some forward planning around the monies there. So that looking at what services do we need, what's our learning from this last year for where we've invested that and how we support it going forward. So we're looking at that piece there. And then internally, we described in our winter plan last year, we've opened up a number of beds over the winter at STH to respond to winter pressures as we plan to do and as we have done. We're now working through and doing the modelling. We've not concluded it yet about. We see a seasonal pattern every year of the demand for beds increasing over winter and then that reducing down in the spring, usually at Easter time. more often than not, that reduces down to a higher level than the year before. So that's a bit we're just modelling through now to be clear about as we come out of winter and we develop our spring-summer plan, what's the number of beds that we need there. And again, looking at demand, we've been doing some work around our length of stay. Our community team have done some fantastic work around virtual wards, so that's the model where patients that otherwise would have been in an acute bed are managed at home. They're reviewed just like they would be in a bed kind of on a daily basis by a clinical team and plans put in place, manage the medication, the therapist support, kind of remote monitoring. And so we've got an increase in demand, but also a change in how we provide services, which is hopefully reducing the impact on our inpatient beds. And it's that bit that we're just modelling through now. So we've not got that full plan going into next year, but we're at the planning stage that we would expect to be at this time of year to work through what do we need across the wider health and social care community, and what do we need within the acute service to provide care for our patients next year.
Thank you, that's really helpful. Really good to hear about the virtual, the virtual wards. I just wondered what the feedback from sort of patients and friends and family is on that. How do they find that?
Yeah, we had our trust board last month presentation from the virtual ward team, and they gave the example of a number of patient stories that were absolutely fantastic around individuals who wanted to be in their own home, who we could support in their own home, and some very important things for individual patients around. They know where their toilet is, they're used to their floor, they're used to their kitchen, that their kind of activities of daily living are so much better by being there, but we can wrap around, we can step them up into services, we can provide our community nursing and therapy teams into their homes. So yes, extremely positive from those patients, and that's why we're looking. We've been doing it for our elderly geriatric medicine patients. We're just working through internally around other options, particularly around respiratory and cardiology, to look to see where else we can step patients into the virtual ward.
Yeah, it's really good to hear.
If I might interrupt, sorry, apologies, but just from my perspective, for the next 12 months, we've got the NHS England 10-year plan coming in May time. That is likely to continue the focus on urgent and emergency care and discharge, but we also expect it to push hard on things like prevention and proactive approaches in the community. And I think, along with all of the programmes of work that people have talked about already and that Michael's touched on around discharge and flow and everything, gives us some real opportunities to make sure that only the people that need to go to hospital are going to hospital, and that we can support people in the community better. And Michael's absolutely right that we've got a great opportunity in Sheffield, because Sheffield Teaching Hospitals has both that acute and community ownership, which has been incredibly helpful in order that we can continue to work in partnership to improve things for people in Sheffield. Thank you.
Thank you. It's really good to hear that it sounds like we're in a really good place in Sheffield in terms of being ready to respond to that 10-year plan when it arrives, and that sort of take things forward, hopefully at the pace for the people of the city. So that's great. Thank you.
A few months ago, my GP sent me to A&E, and once she confirmed I had someone to take me, I was told to go. You need to go now. And when I was there, I mean, she'd sent me for an ECG and some heart blood tests. And while I was there, I kept thinking, surely there was a better area for me to go to rather than clog up A&E. I did end up in the last hour in the same day emergency care unit. Would my GP have been able to refer me to that unit straight away, or did she have no choice but to go through A&E? I have to say it was a really positive experience. The staff I encountered were all excellent, and I did encounter quite a number of staff. But yeah, so would there have been a better pathway so that I wasn't clogging up A&E?
So thank you for your feedback, and I remember you mentioning this when I came last time, and you absolutely weren't clogging up A&E. It's really important that when you're there we provide the services that you need. But yeah, we continue to develop our pathways so that we can get the patient into the right place at the first step, and that's really important. We continue to develop that and open up the pathways for GP referral in. Often that is through A&E, but because they're co-located, on the whole, and apologies that didn't happen, we identify patients and move them quicker. So we've got our single point of access, which is the routing for GPs, which is a phone call for them to phone to describe the patient and then hopefully signpost him to the right way, which might be into STEC or might be into A&E. It's difficult to comment on different clinical pathways, but yeah, absolutely, it's really important we join up all our services so that then we can get you into the right place. So, Chair, shall I take the next 3 slides together fairly quickly? I'm mindful.
Should we go on? Other questions might pop up
sure.
still about the A&E and so on, but let's move on with the presentation. Thank you.
So, next slide, please. So this is a slide that we did share when we came before for Christmas. So to describe this one, so this is the average daily emergency admissions and discharges. Sorry, this is just admissions on this graph, sorry, right back to 2019. And the green, in effect, the paler green is back in time, the darker green is more recent. So this shows, and it goes back to the earlier conversation, in effect, our daily admissions are increasing year on year on year. So that's what the graph shows, and we described that last.
I'll just jump it for anyone who's struggling with the colours.
Sorry, apologies.
I'm going to tell you what I've discerned, and you tell me whether I'm right. Yeah. There's a very pale single dot on the far right of the graph, which represents December 2019.
Correct.
And then the colours increase, so year on year is the line that sits lowest is next.
Yes.
And then they go successively up the graph. So as you move up, the lines are getting darker, so that's each year is going up, and then there's that single dot that's the only data for 2019. That's the starting point.
That's correct. And the 2020 line is obviously COVID year, hence why that follows a slightly different pattern to all the other years. But yes, so the top line, there's a bit of an overlap on the month of August, but yes, the very top line is the most recent one. Thank you. Okay, I'll keep moving through. So bed occupancy. So this is the proportion of our beds that have patients within them. You can see, I think the key message here, we've not put a trend line on, but there is a trend line increasing. We are continuing to use a higher and higher proportion of our beds. Best practice is always to have some beds available. That's then where we can move patients out of the A&E department and manage ambulance flow. Because our occupancy is increasing, it's becoming harder and harder to do that, hence the impact on the ambulance handover. Often when I take particularly our board through this data set, I'll often do it backwards, so apologies. I think that's why kind of you're definitely all one step ahead of me in asking the questions, but in effect this is showing that increase in occupancy because of the last slide, increase in number of admissions. We have increased our beds over time, so this is a percentage increase, so the denominator, the total number of beds that we have got available, does fluctuate by day, by week and by season as part of our winter plan, so it is a bit of a movable feast, but the overall number of patients in our beds is increasing over time.
So just to make sure we don't.
Yeah, please do. Thank you,
so
Chair.
The number of available beds has increased over time.
Yes.
And so a higher percentage today
of a higher number of beds.
Of a higher number of beds is kind of worse. If you sort of it's a higher percentage of provision has been increased,
We have-
but it's more full than
We have
than the old provision.
We have more patients in more beds, and I think it's part of that answer to your earlier question, Chair, in terms of how can all these things be true. This is kind of part of that wider picture.
And just to draw attention to the scale of this chart as well, that it's only ranging from 82 to 92%.
Yes.
So it's just important to get the context that what looks like quite a wild variance at August 2023 is in fact a relatively small variance.
Yes.
In you know, in going between 80 something and 90 something. They're small numbers represented by big
absolutely.
shifts in the graph.
And I think just to underline in all of this data, if we mapped the national data on this, it would follow it very, very closely. So there's nothing that we're seeing in Sheffield around A&E for our target increase in emergency admissions or bed occupancy that is not being reflected elsewhere in the country. Okay. Oh, sorry.
Thank you, Chair, if I may. Obviously, again, this comes back to it comes back to capacity, doesn't it? And with all, with every graph that we go through, and having looked at them before, that it seems like the picture for capacity just keeps getting worse and worse. So the fact that you have said that there isn't really any plans to increase that capacity, it baffles me slightly as we keep going through this. So I just wondered if you could go through the rationale behind that. I know that obviously we're wanting to try and keep people out of beds and keep people safe at home. Obviously demand is increasing and that's putting extreme pressure on the service. So where do we go from here in terms of capacity?
Yeah, so apologies if I was unclear earlier. So we've not firmed up our plans for this next year. We've increased our wards, the number of wards that we have open over the last 3 years. We've increased the number of beds that we've had available over winter. We haven't yet confirmed what number of beds we need and what our plan is for when that drops down in the spring. Apologies if that was unclear earlier. But what we are doing is increasing capacity through things like virtual ward as well. So the national initiative around virtual ward is, in effect, every virtual ward bed is a replacement of a bed in a hospital as well. So could be included in the overall bedding complement. So as we increase the number of physical beds and how we staff those across our acute sites, we also increase our community and virtual ward provision. So that does increase the capacity overall.
Can I just quickly ask what would be like the ideal headroom in terms of empty beds? So I know, there are some ways of looking at a health system like this that might say that empty beds are bad, but I think they're good because it's a safety net and it can deal with a surge and a pandemic. So what would be the ideal headroom in terms of percentage of empty beds at any one time?
I think when we go over 90% occupancy, you can see that on some of these, that's when it becomes really challenging. And as I say, this is over time, so there'll be peaks within the day and within the week sat behind this data. So, but yeah, national guidance around 90% occupancy. And some of that is about, we have different kinds of beds across the organisation, and again, some of the beds that we have, so we'll come on and talk about planned care. We recently opened the Sheffield Elective Orthopaedic Centre at the Royal Hallamshire Hospital. They're in effect ring-fence beds for orthopaedic care. That does mean that the occupancy in those beds is much lower than the rest of the organisation. Likewise, we'll keep beds free for some of the emergency pathways, cardiac and stroke that we talked about. So this doesn't give... Tracking this across different pathways is really important. But yeah, overall, we know when it goes above 90%, that's when the challenges on the system start to
Is that ideal though, or would you? I mean, if you were creating the system yourself, would you go for a higher number of available beds? I'm not going to use the word empty. Available beds at any one time.
I think yes. I think if we had a bed available for every patient when they arrived, I think it's as kind of commissioners and planners, we need to work through how we do that in terms of the resources that we've got and the staffing challenges that we've got. So it's that balance. But yes, if you can run with headroom, then that's what we would like to aspire to. It's managing that within the practical resources.
And just to quickly comment back to the ambulance side of things as well. You've increased the number of ambulances and the number of paramedics. Brilliant. But if there's no door for patients to go to when they get to hospital, you can increase the ambulance service ad infinitum and make it look really shiny. But if you can't offload a patient, so that I think I've got question marks over what ideal capacity looks like in a hospital. But there we go. Something for the future, maybe, hopefully. Shall we carry on?
So, final slide on this section, please, then. So, which, again, we talked about last time. So, the bar chart on the left is the yellow chart shows the number of patients in our beds. So, for context, we have about 1,450 beds on average across STH. So, in the month of November, 226 of those had patients who were deemed to be medically fit or no criteria to reside is the kind of national definition of that. So this is the work that we have been doing, particularly supported by Alexis and the work of her team around how we absolutely create the capacity. So when patients are ready to be discharged, if they need further support at home, be that some care provided by the voluntary sector, by our community services, by the council commissioned or provided services, or indeed going on to a nursing or residential bed, that those patients move as soon as possible. So if we can reduce those numbers down, then that frees up capacity and goes back to the conversation that we've had. So we'd set ourselves a target, which is a grey line on the right-hand graph, which is around bringing down the proportion of those patients to 13%. And the green line is what that has been month on month up until the November data. So we've got further work to do to bring that back on track, but that does then impact on bed availability. And as I say, one way of telling this story would be to start with this slide and then kind of describe the impact that has right back to Adam services in the community.
Thank you. Yeah, I mean, just looking at the numbers, the yellow actual on the left and also the green line on the right, neither show actually any trajectory downwards at all. I appreciate, it's complicated because you've got increasing numbers of beds, as you've just been describing, and a higher percentage occupied. But these are talking about percentages as well, aren't they? So it doesn't, whatever's happening doesn't look like it's really working at the moment, is my comment. I'm not criticising you or anyone, I'm just, it looks quite intractable from these graphs.
I think the percentage, which is the right-hand graph, I think that's fair. I think the left-hand graph is the actual average number of patients waiting, which, yes, hasn't come down, has levelled off. Sarah might want to come in and comment on this, but it has levelled off against increasing demand. So the number of patients coming into the trust has increased. The number of patients delayed has levelled. That might be described as a positive. I think we need to go further because these are patients that we want to support in their own home. For all the some of the examples I gave earlier, we know that's absolutely the right thing for the patient. But then for freeing up beds and acute beds for the next patient that's coming in or through the ambulance to come, it's really important as well. So definitely we've got further work to do. We've re-described what we need to do and the work that needs to happen between health and social care to bring that number of patients down, coming out of winter pressures and into next year. It goes back to Councillor Thornton's question around if 226 patients is a large number of our wards. If we can manage these patients who have finished their acute medical care and support them in their own home, then we don't need to continue to grow our acute beds at the rate that we have over the last couple of years.
Happy to go on?
So that was my very quick run through. Apologies. The urgent care data. So I'm just checking there's nothing further over urgent care. And I'll move on to planned care now. So next slide, please. So just for context, absolutely in terms of, so planned care is around patients whose care, they're not on an emergency pathway, they're more often than not referred in by their GP for planned care across a range of our services. At STH, we provide those services for patients in Sheffield, as kind of in effect the local district general hospital, for patients in South Yorkshire as what's called a tertiary centre, so a number of specialist services that we provide on behalf of South Yorkshire. But then we also provide a number of pathways for patients regionally across northeastern Yorkshire, but also nationally as well. So it's all of that we provide at Sheffield. We saw nationally the impact of COVID on the time that patients wait for treatment. Prior to COVID, we were one of the best performing trusts nationally on the 18-week performance. We were consistently in the top 3 performers nationally, and we had no patients waiting over a year. The number of patients waiting nationally increased through COVID as we paused our services, and then as we looked to recover and reduce the time that patients wait, we've seen our waiting time come down, but we've got further work to do on that. So the next few graphs just give the headlines from a data perspective, and then very happy to talk to you around individual services. So the next chart, please. So apologies. So this is a similar run chart. So this is the time that patients wait has been measured nationally, but against an 18-week standard. And so the standard is a proportion of patients that from referral to treatment within 18 weeks. And you can see again, this absolutely mirrors the national performance. You could almost layer it on top. A reduction in the time that patients wait. The data shows a decline in 2023. That's around how the numbers work. So the number of patients we had waiting reduced significantly because GPs were not referring patients in through COVID. As that number increased, then the proportion waiting decreased as well, hence the reduction. We've levelled off since 2023 at around 61-62%, which again is a national position on this. Nationally, just to give context, so where the 42nd best, worst, depending on your view, I want to improve this, out of all trusts nationally, we're 42nd out of 119. So that's kind of where we're sitting in context. But commitment is to get nationally to move towards 65% of patients being treated within 18 weeks by the end of March 2026. So we've got improvement to be done over this next year and plans in place. I'll just take the next graph if that's okay, and then I'll put, yeah,
Just on this one, just trying to get an understanding of it. So go down is bad, isn't it? Going down is bad.
It is.
Yeah,
Yes.
yeah. Okay.
Yes.
So we've now got 62% of patients who aren't their pathways aren't complete by 18 weeks. Is that a correct statement?
62% of patients get there. So if there was 100 patients, 62 of them would be treated in under 18 weeks, and 38 of them would be treated in over.
I've got it. Sorry if I'm being daft. Thank you.
So just the next slide. So the focus nationally is, whilst we're looking at overall the patients waiting to be treated and the proportion within 18 weeks, is absolutely looking at our longest waiters. So this is the number of patients who've waited at the point they get treated, treated within 65 weeks in total. I'll just pause it. Sounds like we...
Apologies, we're just dealing with some water coming in to the building. Okay, we'll carry on. Thanks.
Okay, thank you. So this graph, shows the total number of patients who were waiting over 65 weeks for their treatment. The highest proportion of these were patients waiting on a neurology, so head neurology pathway. We provide the South Yorkshire service for neurology, so we in reach into Barnsley, Rotherham, Doncaster, so it's patients waiting for all of those. This data goes up to November. At the end of January, we expect to be under 200 patients, so we've made some significant inroads into this in December and January. We continue to track these patients. Again, this is in line with the national picture in terms of particularly tertiary centres like Sheffield, where we have very particular individual pathways. Unfortunately, a number of patients continue to wait. So the focus from an STH perspective and the purpose of sharing the graphs was the national intention to get back to 65% or to move to 65% of patients overall being treated or not waiting for more than 18 weeks, but then absolutely focusing within STH on those patients that are waiting the longest. And so to give some flavour of the things that we've
Sorry, just on this, just so that we really understand. So the downward trajectory on this is good or bad?
Good. I want to get this to 0.
But on the previous graph, the downward was bad.
Yes.
Okay, and this isn't presented as a percentage, just to make that clear.
This is the total number of patients.
Total number of patients. Okay.
Do you know how much that represents as a percentage? Sorry to put you on the spot.
No,
so that we can have a look at it.
So the total number of patients waiting on our waiting list is about 96,000 patients. So 200 of 96 is an extremely small percentage. So this is about a very small number of patients that wait a long amount of time. again, nationally, that's what we're doing, bringing in those very longest waits whilst then looking at the overall number of patients waiting, how long they wait for, and bring this down. So the work that we've been doing this year is absolutely about understanding our individual pathways, ensuring we've got the sufficient capacity on those pathways to treat these patients, but then also working across the primary and secondary care interface, very similar to the work that we've described on the emergency pathways around advice and guidance. How do we support GPs to manage some of these patients? Where might we refer to other services? So physiotherapy is a good example for patients waiting for orthopaedics. How do we support them to wait well or get them into other services so that they're not waiting? Sorry, Chair.
So I was just going to say that, go on, Councillor Mallinson, I'll come in a minute.
Just to summarise so everyone's absolutely clear. So the previous graph is showing that things aren't looking great for the people who are waiting longer than 18 weeks. That's sort of not a particularly rosy picture at the moment. But the 65-week wait, the longest, is improving quite well.
Yes, so the national plan and the STH plan has been we need to treat more patients, we need to reduce the time that patients wait, but we need to absolutely focus on the longest patients. So we've seen movement on this graph and improvement on the longest waits. We've held steady on the overall average time that patients are waiting. As we bring the tail in, we then need to keep bringing or then increasing the proportion of patients that get treated within 18 weeks.
So if I'm a patient who's in this 65-week category, unfortunately, I'm not, but if I were, I might feel that I'm being prioritised because there's a heavy priority here to deal with patients who have been waiting that long. If I'm a patient in the 18-week, still in the 18-week pathway, is my treatment likely to get pushed back and even into the, tipped over 18, long over 18 weeks because of reducing the longest wait? So you've got your longest waits, which is a horrific situation for anyone to be in. Obviously we want to deal with that. But is it having an impact on the shorter waits? I.e., are they getting longer because of are we doing a weighting scale thing here?
So the way we've always prioritise our planned care is clinical priority and then length of wait. That's the right thing to do and what we've always done. So at no point in bringing in the very longest waiters have we compromised then the care for those patients, where our clinical staff have triaged, reviewed the referral and said, I need to see that patient in 2, 4, 8, 10, whatever the number of weeks. So clinical priority is the kind of first step. And then we have always prioritised the longest waits. Pre-COVID, as I say, we didn't have any patients waiting over 52 weeks, so the longest waits were under that, and within that we managed the 18. Unfortunately now on some pathways, some patients are waiting over 65 weeks and we are prioritising those. Very often than not, because the longest waits are in very particular specialties, so neurology, we are in effect treating everybody in clinical and time order series within neurology. That won't have an impact on the waiting times in orthopaedics, for example, where the profile of the waiting times might be very different. So we wouldn't be impacting, as described there, from one patient to another. We're prioritising our capacity on clinical need and then length of wait.
Any other questions? No? Lucy, yeah.
Sorry, thank you. My brain was just churning slowly there, I think. Just in terms of waiting times, often what's really sort of adds to the distress of patients who are waiting longer than they would want to for their care is the lack of knowledge or kind of not knowing really where they are on the list, what the average wait time is. As you've been describing there, the way you are sort of juggling, I guess, constantly those different sets of clinical needs and different pathways, how is a patient and a member of the public meant to have, how can they access sort of, you know, some kind of information that's going to give them an indicator of how long they're likely to have to wait?
Yeah, that's a really good question. It's really important that we support patients, but also their referrers, so GPs, in terms of knowing the time that it will take, setting expectations. Unfortunately, we want to improve on these, but being clear about the expectations is really important. So our waiting times are published as part of the national data set. I think given some of the conversations we've had here, I absolutely appreciate that's not always straightforward, and I think that's why the kind of national push is about getting back to the 18-week wait. That was kind of embedded in the kind of national conversation, and patients knew that they had a 95% chance of being treated within 18 weeks. I think whilst we're on the recovery journey, that will continue to be a challenge. The things that we've done is absolutely being clear with our staff to support our patients about what are the local times for the pathway that they're on, or the clinician that they've been referred onto, about keeping patients safe whilst they wait. So making sure that we have that dialogue with patients so they know if anything changes in the care. So going back to the conversation we had about clinically prioritising patients when we first get that referral, really important that we have that opportunity to review that, and we have processes across the majority of our pathways where we proactively review that waiting list to check that nothing's changed, but then also make sure that the patients know how to contact us if anything changes from their perspective. And then lots of national initiatives and work that we've done locally about supporting patients to stay well whilst away, and also particularly if they're on surgical pathways, some of the work around preparing for surgery. So a number of different schemes that we offer around exercise and therapy and weight loss, which absolutely use that time whilst patients are waiting to get them into the best possible health, so that when we get to provide the treatment, that it absolutely maximises the outcome. So it is a challenge. We've seen, particularly as we've had a growing number of waiting lists, there are more conversations between our staff and our patients about how long are they waiting, and how we support them with that.
Actually, just one final question. I wonder what Sheffield looks like compared with other core cities. So thinking about, about really big urban centres, is our population unusual in its needs compared with other similar places?
As I noted earlier, we compare our performance across a number of different benchmarks, but large northern acute trusts, so that would be the kind of Leeds, Liverpool, Manchester, Sheffield, and comparable there.
So, but I'm just thinking about the actual needs of the population. Is there anything different about Sheffield in terms of, presentation of comorbidities and complex needs?
I don't know whether Sarah wants to come in from a commissioner perspective on that.
I'm not aware of any huge differences. Our demographics are not that different if you take all the northern industrial cities, I think. I'm happy to look at it, and if it's different, to come back to the committee, if that would be helpful. Yeah,
it's an interesting piece of information for us, I think, just to understand ourselves in a wider context, especially, we've got a whole council and whole city remit, really, to try and improve population health. So understanding if we've got any peculiarities compared with other northern cities might be useful. Thanks, Sarah.
Okay.
So the recommendation for this report is that it is noted, the update is noted. So thank you for bringing the update, and I think we all agree that we note it. I think in terms of bringing back another update in the future, just moving on to partly onto our work programming item. So we also have the winter plan item from you, which you brought in November, I think, this last time. It has been slightly earlier in October in previous years. November felt a little bit late for that discussion because winter's kind of already getting underway, and it was, I guess, a little bit difficult for us to have a discussion about planning ahead when you're just entering the real thick of it with the winter period. Thinking maybe we can bring that forward to September this year and have that discussion earlier, which will allow us to participate in, you know, a little bit more proactively in the planning side of it, and to involve public health in that as well from the infection control point of view. So that would be a proposal I'd like to put forward to members, and then to consider alongside that when we might have a future update on the rest of this, whether, Michael, you think it all sits together, and Sarah, whether you think it would be useful for that all to sit together with the winter planning, or whether it's more useful to separate them.
I think from my perspective, I'm happy to, they are two slightly different things, but they all come under the banner of healthcare that we provide for our patients. So I'm very happy to be guided by you, Chair, into how you'd like to do it. I'll respond in either way.
Members have any thoughts about that? The timing of a future report on this topic and working with the winter plan?
Thank you. I suppose I'm just conscious that we have spent quite a long time talking about this today, which is absolutely the right thing, because it's really important. And just suppose just looking at what else on the agenda, whether we'd have time to have a full discussion if we're merging them both together, or maybe it might be better to keep them separate. I don't know.
I didn't, but I absolutely accept what Councillor McClean said, but to just put a contrary view, it's useful to have the combined discussion, because then you're picking up, you're getting a complete picture in a sense. But notwithstanding the fact that it probably needs to be almost a dedicated meeting for it.
Julie?
I think Laura makes a good point. However, if we were bringing this back in 6 months, would we just be wanting to look at the 6 months, because we've been looking at this over a longer period? So I think, you know, we've now got this information, so we would just want to see what the improvements are of the 6 month period. So hopefully it wouldn't be such a complicated and long debate, and may have some useful information in there that we could take cognizance of when we are looking at the winter plan, because depending on how that goes, may have some bearing on what happens with the winter plan. So it may be helpful to do it all in one session, even if it's a little bit longer.
I might just take a quick show of hands then, just to see where the opinion lies. So to take, are we happy to bring the winter plan item forward to September first of all, to allow a fuller discussion around that? We're happy with that. And then, so to align the next update on this, we wouldn't be expecting, you know, you have to go back to scratch on it. It would just be updating, and presumably that's data that you look at all year round anyway. So that wouldn't make it more arduous for you. So to bring this, the next update on this in alignment with the winter plan, and then future years, they could be aligned year on year. There's nods, or another view to separate the two items. No. So we'll bring those together in September, if that's all right. Might take a bit of pressure off, because I was aware how pressurised everybody is at this point of the year to pull this kind of report together. I know that was quite difficult for you at this particular point in time. So hopefully that will ease that pressure a little bit as well, and allow for a fuller discussion around urgent, planned and winter care. Thank you, that's great. We've just got the rest of the work programme to discuss in 3 minutes, so hopefully we can finish on time today. Thank you very much, Adam and Michael and Sarah, for joining us. So our next meeting is March the 25th, and we have on the work programme an item on long COVID rehabilitation clinic to look at outcomes, waiting times and capacity. We have continuing health care, which is an item that's been requested by Health Watch, which we'll talk about in just a second. And we have also a new item, the Harold Street Medical Centre, which has been brought forward by the ICB on the basis that a consultation on the relocation of that practice, or the closure of that specific practice, which was a single-handed practice, The consultation has just finished, and so they'll be drawing up a report on that and keen to bring it up to us in March. That's their timescale that they'd preferred. So we've added that item to the work programme there. Can I ask for just a bit of context to the continuing healthcare item? Lucy, Laurie, we've got there's a note here of what it is. Did you want to say anything about that, Laurie?
The committee have got in the packs the work plan paper and obviously appendices as well. I think from my knowledge, we received a letter from the chair of Health Watch in Sheffield about continuing healthcare, requesting that it's considered by this committee. So the proposal in the pack is that we bring this to the next meeting, which is in March 25. I don't know if Lucy has any wider context on it, but obviously we'll work with you on bringing the item forward.
Yeah, thank you.
Just it does mean 3 items in that meeting, so I'm just keen to get your opinion of how this is going to fit, how much content we need at that stage if we bring it in March.
Yeah, there's some quite chunky topics on that meeting agenda, aren't there? I'm conscious of that. I don't know whether or not at that stage it's almost an initial report from, it's obviously both the ICB and social care that are relevant to that topic, and I see you've got Ian and Alexis down as the leads for it. In terms of why we raised it with the committee, just to sort of briefly describe that since the ICB was formed, you've had the sort of coming together of 4 separate teams to deliver continuing healthcare that have now been aligned across South Yorkshire to work under a sort of joint policy, and they've been combining their policies and procedures as well to deliver that to the population. So the question really was around how has that alignment impacted the experiences of people? I don't know how much information they'll have to bring, so it's slightly difficult for me to kind of anticipate really the amount of time that it needs. From my perspective, it is quite a complex area because it does involve both health and social care. But it could be that they bring some initial information that helps us to refine our sort of questions, and we ask for it to come back at another stage. I'm not sure.
I think that makes sense. I think we might ask for a sort of status quo report and a summary of the issues that have been raised with Health Watch. I know you've already sent us some information, but maybe if you can frame that in a way that indicates why you've brought the item to scrutiny and what the kind of underlying issues are that you've been hearing about, and then we can begin to sort of cross-match that with what the status quo is with the ICB and with the council. So we'll keep it as a relatively compact item in that agenda, but we will start to explore it. Does that sound reasonable? Okay.
So just to add, I'll ask Deborah to work with you, Lucy, just to scope that item. It feels like it's a good step because, as you said, it could get into quite significant territory, but it gives the committee an opportunity to just scope out what the areas of focus might be, any issues and challenges, and then that might set further work plan items or workshops depending on what we get into. Thank you.
So that's the last meeting of the year. Laurie, yeah.
I'll be really quick. I just noticed it's turned 12 months since we had continent services on the agenda, and they're due to come back. I just thought I'd raise that just as a reminder to us. It'll be good to hear from them again, because 12 months has passed since they were here.
Scheduled for next year, isn't it?
I've read the dates wrong. My apologies. Yeah, I've got my years wrong, but yes.
Yeah. So the last discussion was January 24. So it will be a year and a half.
Yeah, that's fine.
Going on by the time it comes again, but yeah, it's on there for scheduling. So March is the last meeting that we can really fully appraise, I think, before the end of the municipal year. So everyone happy? Any other points about the work programme? Happy? Okay. Great, so the next meeting is on Thursday the 20th of March at 10 a.m. And that concludes our business for today. Thank you very much, everybody.